really been many different things coming together to put us where we are today and to help take us into the future. And if we can do this. So I'm going to be talking about prevention and wellness. I think that's where the most exciting activity is. How that fits into what's been happening with the ACO movement, and how that fits into where people are challenged by unnecessary rehospitalizations and the fines that are associated with that. So this graph is one that I put together when I was trying to figure out, having supported the telemedicine industry for the last 10 plus years, trying to figure out where we've been, where are we, where are we going. So for many years, in the 90s, we started with telehealth, and you've heard a lot about that today. The challenges perhaps around licensure, the challenges around privileging and credentialing. And there was just a certain amount of slow progress that was made from the 90s to the 2000s. And it's when we hit the mid-2000 timeframe that I think things really started to change on many fronts, and why where we are today, we can really move more rapidly forward to bring patient care out to the patient, into the community, into the home, and to help keep them healthy and well, and help address this challenge that we have with the chronically ill and the aging population. So if you look at what happened in the 2005, 6, 7 timeframe, we saw a big change in technology, right? That's the point in time when we start to see things like YouTube, where people are starting to embrace video, even kind of bad video if you look at the quality of the original YouTube stuff that we saw. And at the same time, in the 2005, 6, 7 timeframe, you saw high-def systems coming onto the market from Polycom and vendors that produce the collaborative video solutions. And in addition to that, we saw the pricing go down on a lot of the collaborative video solutions, and they became easier to use. So those were certainly a lot of the barriers that existed early on. I would work with doctors and they would say, oh, it's not reliable, I don't care, the image isn't that great. And you had to kind of drag people to the table. And in the early adopters, you had these people that were very bright, very dedicated, and they really were the champions of the early telemedicine initiatives to try to get everybody excited and doing something that was really against the odds or kind of swimming uphill. In the 2005, 6, 7 timeframe, we started seeing an environment start to change that was going to make that battle a little bit easier. And that's making the video collaborative solutions more cost-effective, easier to use, and having the general public through YouTube exposed to all these videos all the time whenever they wanted them, showing them all types of things, and really starting to set the stage for what the patient expects and what the providers expect in terms of getting information and connecting with people. So on the far side of this, looking in like the 2009, 10, 11 timeframe, what we found with the stimulus bill, at the time it hit, let's see, so the economy went bad at the end of 2008. In the beginning of 2009, we had the stimulus bill. And this is when we really started to see a lot of funding that it has gotten us to where we are today, where broadband is really going to be rolled everywhere, out to the home, connecting everybody, so that they'll be able to use the video that they've started learning to expect, and so that they'll be able to better utilize resources. So in 2009, in the stimulus bill, I don't know, I actually do one more survey question. I've read the stimulus bill. It's 409 pages long, and I think for some of you, you might realize that not only am I old, but I'm also kind of boring. So how many people in the room, raise your hand, have actually read the stimulus bill? I've asked this question every year, so you're the second individual that I've found that's read this. The interesting thing I found in the stimulus bill was that for the first time on a federal stage, the words telemedicine, telehealth were littered throughout that document. And what that said to me, in addition to how the money was going to be spent, if you looked at the stimulus bill, there was $7.2 billion for broadband. There was also $2 billion for the Office of the telehealth, and $2.5 billion, for DLT, and another $2 billion out to community health centers. So I don't know if at the time I'm looking at this and like $2 billion to the community health centers, what does this really mean? And I think that was the first time that we got the real exposure to the fact that we're going to be taking care out to the community, out to the patient, closer to where they are, and trying to get movement toward this prevention and wellness activity. So the stimulus bill was in 2009, and in 2010 we had the Affordable Care Act, and I wasn't surprised to see that there was another $11 billion that was in there around the community health centers. And if you read in the early grants that were issued for that first $2 billion to the community health centers, the number one example of what you could spend the money on in that grant guidance under health information technology was telemedicine equipment. So this really said to me that the government is gearing up and getting ready to go out and deliver and support a different healthcare model. I don't know if any of you have, maybe raise your hands if you've seen or looked at the Dartmouth Atlas. Anybody in the room? If you just Google the Dartmouth Atlas, you'll know that they went through and looked at healthcare delivery systems across the United States and found it interesting that you could treat congestive heart failure in one state and have the average patient be costing $100,000 per year and not doing very well. And you could go to another state and find that the congestive heart failure patient is costing half that amount of money and is doing really well. So that, to me, when you think about the timing of all of this, it said that there's possibly a way to do things so that you can treat congestive heart failure better at less money and still have a better outcome for that patient. There was an interesting video that Frontline did. If any of you are interested, you can contact me, deb.jeffries@polycom.com. In the Frontline video, which came out, I think right after the across the board and support that transition of care. These are some additional reasons that the original studies found. Inadequate relay of information by hospital discharge planners to patients, caregivers, and post-acute care providers. Poor patient compliance with care instructions. Inadequate follow-up care from post-acute care and long-term care providers. Insufficient reliance on family caregivers. I think this is going to become more and more important as we see this aging population. The deterioration of the patient's clinical condition and medical errors. So, all of these situations, I think, being with Polycom, and I look through what's happening in healthcare and how can we help, to me, the underlying thing is it's all really based on being able to collaborate. You need to be able to do case management where you can bring everybody to the table. Imagine being able to bring everybody in over video, whether it's the adult child that lives 1,000 miles away, whether it's an aunt or uncle or somebody that's going to be part of the care of that patient once they return home, maybe the case manager, maybe the primary care or the specialist. Having them all on a multi-point interactive video call that enables you to find out, well, guess what? Dad can't go home with just mom there to take care of him because neither one are going to understand those instructions and they're going to get confused. So we've got to bring Aunt so-and-so into the house for a few days, or maybe the adult child is going to fly to that part of the country to help with that parent for the first 30 days of the recovery. Discharge planning was mentioned as a big one, and I think the scenario I just described has to do with bringing all those people together over live, multi-point interactive calls from anywhere. And the second part of that is imagine being able to send that patient home with a tablet that has a single button that you can push on that illustrates for them in the language that they understand what are the red flags associated with their discharge from the hospital. And it can be a generic set of instructions in terms of if you put on too much weight, if you notice a fever, if you're vomiting uncontrollably, immediately get in touch with the case manager, the ER, whoever, right? So you can now start to think about enabling that patient to have the feeling that when they leave the hospital that they're not on their own, that they're going to have this technology that can keep them connected during that transition and help them understand what their discharge plan is all about and help them to adhere to it. Post-acute care. So imagine the case manager being able to...
And probably physicians aren't the best ones to do that. There's a thing in pregnancy called Strong Star grant, just went out for it. It was a group prenatal counseling kind of model where you establish peer relationships with pregnant women so that they encourage each other for, not to smoke and to exercise and things like that. So do you see that as a role in healthcare as it evolves, and it's a little bit different kind of approach, right?
It is, and I just touched on that briefly, but I think it's the most powerful part of this because at the end of the day, we want to support prevention and wellness, but that's going to mean modifying that patient's behavior. And that peer-to-peer model is one of the most powerful ways to do that, to really be able to have someone that you can identify with, share a story with you, that then is more apt to have you change your own personal behavior. And it can be anything from, if it's your fishing buddies and they're talking about stuff and say, hey, if I stop smoking 1 pack a day, this is what happens. I don't cough as much and whatever. When they get those anecdotal stories from somebody that they are on the level with, they're more apt to change their behavior than they get from the doctor or the nurse saying to do that. I think what's interesting is With collaborative interactive video, you can bring in a moderator to make sure that the stories that they're sharing are valid and that they're not, hearing some crazy thing that's not really appropriate to change their behavior. So if you think about all of us being able, for example, to get on a live interactive multi-point video, and we're going to talk about, say, exercise and its benefits or whatever, you can really bring in this big group, talk about what's good about it, what are the problems, and have that person who's an expert in that sitting in to say, well, that sounds really good, but I would just change it a little bit to this, to make sure that that peer-to-peer message is the correct one.